Welcome, everyone, on behalf of the Institute of Health Economics. My name is John Sproul, and I'm the Senior Policy Director at the IHE. My CEO, Dr. Kate Harbeck, is currently on a plane to Montreal, but she sends her greetings. This is hopefully going to be a useful learning session to provide some baseline knowledge for those involved in the important activity of looking at activity-based funding in the province of Alberta. We will be posting the video of the presentations as well as the PowerPoints online and be sharing that with you. And we hope to have a page on our webpage for future webinars around topics of interest and also some key resources, because I think this is a very useful and important initiative of the province and want to be able to help support that as much as possible. So this is called the what, why, and how of activity-based funding, or what I think we are now calling patient-focused funding in the province of Alberta. And I've personally been involved in this, looking at this issue since 1992, 33 years ago in pre-regionalization days in the province, where we had a short-lived experiment. And for the next 15 to 20 years, many other jurisdictions moved quickly to put activity-based funding in as a policy instrument in their health systems. And we had a brief reconsideration of an agenda for activity-based funding post-formation of the Single Health Authority. And it was actually 15 years ago, in 2010, in this same room, we had a national conference which we hosted with CIHI and on activity-based funding with colleagues from Europe, from England, from Australia, and from the various Canadian provinces. And other provinces moved actually to explore this approach, but did not accelerate those efforts in Alberta, while having what many felt were ingredients to put this policy option in place in province of Alberta more effectively actually than a lot of other jurisdictions. So it stalled a bit again. It's certainly not a panacea for everything or an existential threat, but is a useful tool in the toolbox, which I think we'll learn today. We have two speakers, Dr. Jason Sutherland and Dr. Glenn Sumner, and they'll be giving two presentations, and afterwards we'll have a question-answer period. I'll run around with the mic, and you can ask questions of them. I'll just introduce quickly Dr. Sutherland is Professor and Director of the Center for Health Services and Policy Research at UBC, Faculty of Medicine, and he's also the Editor-in-Chief of Healthcare Policy and Associate Editor of Health Policy, those two journals. And Jason has been a bit lonely as one of the few academics who's been studying funding models extensively in healthcare in Canada and conducting research evaluating health system funding policy, and has advised many governments in healthcare funding policy, particularly in 4 Canadian provinces. And Dr. Sumner is a Calgary-born physician who first practiced rural medicine and then returned to specialist training as a cardiologist, and he works with the Libin Cardiovascular Institute. And he also completed a Master's of Health Economics in the London School of Economics and was a visiting fellow last year, interestingly looking at the history of activity-based funding in Alberta as a major initiative. And so he's directly involved with the current efforts underway in Alberta, which he will explain. So I will pass over to our first speaker. Please join me in welcoming Dr. Jason Sutherland.
Hi, everyone. Everyone can hear okay? Thanks very much. It's really nice to be back in Edmonton. I haven't been here for 4 or 5 years. There's no snow on the ground, although still pretty dusty. Great to be here. And thanks to the Institute of Health Economics for the kindly invitation to talk about something that I did a lot of work on about 10, 15 years ago, as John intimated in his opening address there, that a lot of provinces were on the cusp of thinking about implementing activity-based funding, British Columbia, Ontario, and Quebec. Things sort of stalled out, and I'll be talking about that. And it's been a hard place to do healthcare funding policy research because things have been so slow to evolve. A little bit about me. I do healthcare funding policy, and I work mostly in Canada, in the United States, a little bit in Europe, and I have worked on the implementations of activity-based funding in Ontario, did some confidential advising in another couple of different provinces, and have done bundled payments in Ontario and down in Washington, D.C., where I spent a few years as well, too. So I'm delighted to be here today to talk about activity-based funding, which is a precursor to much more complicated models, which some countries use as well, too. So global budgets are still the predominant form of funding acute care in all provinces. There are provinces that use activity-based funding that I'll talk about, but it is in conjunction with global budgets. So they are not in any province the sole mechanism for funding acute care, and that there are a variety of methods used for funding acute care. So I think if you're aware of the literature in the area, and I'll just put some of the highlights and lowlights of different funding models here and contrasting global budgets with activity-based funding. You know, I think a lot of payers, being government or its designated authorities, have run up against the limitations of global budgets and have started to look for another way. And that includes, you know, how are global budgets formed? How are annual increases designed? Is it just on patient population growth, or are there acuity adjustments? And there's no clear mechanism for moving global budgets forward that is really all that transparent. Whereas on the other side, the proponents of activity-based funding list a number of benefits to activity-based funding, including it creates financial incentives for stimulating work and cost efficiency, increased volume, which could affect wait lists, so shorten the wait lists for elective surgeries, some competition between acute care facilities for more patients, which is something we see in the downtown Toronto area, and encouraging more benchmarking among peer hospitals. So there are benefits, or perceived benefits, to activity-based funding that we do hear proponents of both methods talking about. So what is activity-based funding? So activity-based funding is a method of funding acute care based on the volume and the type and complexity of patients that they treat. It could be medical or surgical, irrespective, that is based on the volume and type of patients, that they are remunerated on a case basis. So there's a remunerated level for each type of case and each type of complexity. Sometimes they're split by sex, sometimes they're split by age, but they stratify the payment levels based on the type and the volume of patients. And that is associated with the revenues to the hospitals for activity-based funding. So what do we know about activity-based funding? Almost all of the OECD countries use activity-based funding to some degree. Okay, this is not a new policy. These were implemented over 20 years ago. Germany, England, Finland, Sweden, Ireland. These are all countries that use activity-based funding for remunerating hospitals either partially or fully. It is often combined with other methods. So, for example, in the Nordic countries, and I'll cite out Sweden and Finland, they have a mix of global budgets and activity-based funding because they perceive that activity-based funding is not appropriate for funding the most complex and rare conditions. So they want to make sure that there's no jeopardy to hospitals providing that type of care. So they use a mix of funding policies of global budgets and activity-based funding. Then I'll switch gears a little bit and say that Ontario and Quebec have both implemented, to some degree, activity-based funding. That's my understanding. In Ontario, the range of hospital revenues associated with activity-based funding is between 20 to 30%, and they are called QBPs, or quality-based procedures. Now, don't let the name confuse you. There is no aspect of quality associated with QBPs in Ontario. It is a volume-based measure for which there is a set price that remunerates to hospitals. A number of prominent organizations support the expansion of activity-based funding, include the Canadian Medical Association, the Ontario Medical Association, Ontario Hospital Association. Some of the national blue ribbon panels have also recommended the expansion and use of activity-based funding over global budgets as a way to create financial incentives for acute care hospitals in the provinces to become more cost efficient. So, activity-based funding is combined two elements. One, there is defining the product, and the second element is defining the price, both of which the payer does. So that means that the agency that's going to be paying in activity-based funding, called the payer, generally gets to define what it's paying for. So in different countries, they use different, what they're called case mix algorithms for defining the products that they're willing to pay for. So in Medicare, so this would be the largest insurance program in the United States, it uses diagnosis-related groups, or DRGs. In Australia, they use the Australian Refined DRGs. Most countries have their own version of setting what the product that they are willing to pay for. Okay, so that's really important because as the person or the organization holding the money, they get to define what they're willing to pay for. The second element that's really critical is setting the price or the value that they're willing to pay for the products that they define they say they want to pay for. And in many countries, they collect data to be able to derive prices. So for example, in Ontario, they use what is called the Ontario Case Cost Initiative. And this has been running for about 20 years under different contractors to collect patient-level activity-based costing information in the hospitals. Now, not all countries use the same activity-based costing approach. Some use charge data like they do in the United States, and they manipulate charge data to try to infer what the hospital's prices are. Other countries use other algorithms to try to infer what the costs would be to the hospital. So using cost information, they can set price information. Now, costs and price are not synonymous. One is the cost that the hospitals have of generating the outputs. The other is the price. And the price is the amount that the payer uses to signal how much they want of a given product. So I don't have that many slides, just a couple more, bear with me here. And I'm going to summarize some of the research and experience that other countries have had that hopefully will be beneficial to Alberta as it contemplates activity-based funding. So, activity-based funding, there's some really quite clear evidence of what it does and what it doesn't do. Like all policies, there are trade-offs involved, so we are quite aware of the limitations of global budgets. But now there's quite a bit of evidence regarding the impact of using activity-based funding. And that is it tends to increase volume, it tends to shorten length of stays, it also tends to increase prices or increase spending on the payer, which makes sense because you get more volume, you get a higher cost. There's little evidence regarding the effect on patient quality. There's mixed evidence around cost efficiency or the cost per case. And there's very little evidence around geographic access and how that might be affected by healthcare funding policy, and little also evidence around how it affects equity of access among different groups as well too. Does it preferentially guarantee or retard progress and access to some subpopulations? There's not good evidence yet. And there's also no evidence around whether or not activity-based funding improves evidence-based care, effectiveness, provider engagement, say with physicians or with nursing leaderships, but neither do global budgets. But I think it's really important to point out the pros and the cons of making choices of different policies. So, there are many people, detractors of activity-based funding, and it's worthwhile understanding what their concerns are. So I've highlighted the 5 most common ones that I'm able to find searching through policy documents. And the first is that there are concerns that given that there is an emphasis on increasing volume and cost efficiency, that hospitals will cut corners to become more cost efficient. Now again, there's not a lot of quality on this, but I'm just articulating what the concerns are. Secondly, that access for some hospital-based services might be negatively impacted because they're not profitable to different hospitals. Third, that patient experience will suffer because they feel rushed through the process of admission all the way through an expedited discharge. And then fourthly, that hospital leaders don't have the experience to implement activity-based funding, and as a result, it will jeopardize local hospitals' ability to financially govern. And then lastly is that there's not a robust infrastructure in place to be able to manage the implementation process or the ongoing revenue-based models for hospitals among senior hospital leaders. So those are the concerns, and I think it's well worth knowing what they are. And then I have a slide here emphasizing the value and the impact of setting the price, because the price for the products is really incredibly important, because it's the signal to the acute care hospitals of how much to do of different activities. And when you set the price too generously, hospitals, or ones that are effective financial managers, are going to understand the difference between cost and price and jump into the breach and do a lot more of that activity. So setting the price is really important. In some work that I led in British Columbia after its 3-year experiment in British Columbia with activity-based funding, found that some hospitals could even run on the weekends, paying their nurses double time and still make money. So if you want to really push through throughput, well, then you set your price really high, and the hospitals will figure out that they can make money, and they will do more, and they'll run double shifts, and they'll work, not to 2, they'll run the ORs till 5 or 6. So, hospitals, some of them can be very savvy in how they use activity-based funding models. Secondly, in this slide, I also want to emphasize that British Columbia did implement a 3-year activity-based funding policy in a limited way, and after 3 years, they stopped it and went back to global budgets. So it wasn't always all in forever, but that they tried it, and they apparently decided that it wasn't effective, and they went back. And it's also worth reflecting that the infrastructure upon what prices are built upon, there are different ways to collect that data to try to infer what costs are so you can build up pricing models. There's activity-based costing, but there's also the manipulation of charge data. There's also micro-costing studies that can be done in the hospital. So it's a very complex landscape, sort of either technologically or methodologically, to set up what the cost data is upon which you're going to set your prices. Now, I just have a summary slide because I just have 2 more slides to talk about, but here we are, talking about implementation challenges of activity-based funding. And this is a synthesis of the papers that I could find that talk about the implementation in other countries. So for minimizing confusion and frustration among payers, so the government, and also the providers, which would be the acute care hospitals, being super clear about what's in and what's out. Because if there are ambiguities, it will create problems for the whole policy. And aligning funding to impact, that is determining how much activity you want to create financial incentives for, because it will increase costs, which is reducing the risk of unintended impacts. So when Australia and the state of New South Wales implemented activity-based funding, they set caps on how much volume increase they were willing to tolerate and pay the full price. And after the cap was reached, they discounted the price so that there was a weaker incentive to increase volume. So it set a marginal pricing cap. Empowering meaningful changes, and this is something that we saw in British Columbia, and that we did detect a noticeable impact in the volume of care provided that was affected under the activity-based funding policies. However, they were only in one health authority's hospitals. So that is that there was some reluctance in other health authorities' hospitals to chase the financial incentive because they never believed it was going to be sustained. Now, given that it was a 3-year implementation and then the policy was killed, maybe they were right, or maybe the policy was killed because they didn't go after it. but there needs to be a longer-term vision for hospitals to respond to the financial incentives. And then thinking about supporting a successful transition. So at what pace do you implement activity-based funding? At what volume expectations do you want to have it? How much change management are you providing to the hospital executives? And down at the unit levels that are going to be generating the volume, have to be really clear about that. Ensuring quality is maintained. So monitoring whether or not there are changes in hospital quality associated with potential increases in volume. So does it go down? Does it go up? Is it flat? People have to be at the wheel of understanding whether or not there are changes in hospital quality associated with a big policy shock like activity-based funding. Also, there's also the coding response to activity-based funding, which has been seen in a number of jurisdictions. That's called upcoding. That is where health records puts either spurious or tenuously linked diagnoses into the discharge abstract database to increase remuneration levels associated with case mix-based funding. This was clearly identified as a major problem in the Ontario implementation of activity-based funding, where there was a very significant hospital response in the coding of hospital records. So you have to have clear guidelines and accountability for coding quality, not just the volumes. And then laying the foundation for success for policy change is being prepared for changes in hospitals, because you can't necessarily predict how hospitals' behaviors and activities are going to change associated with a major policy implementation. Are they going to shift to do more work in that area? Or are they going to shift to do less work in that area? You just don't know how hospitals are going to respond and how their senior executives consume the information that they're getting, both from the payer but also internally with regard to their own financial positions. And lastly, reducing barriers to change. So that is preparing for impact to other sectors. And if it is true in this setting that there is higher throughput and volume increases and wait lists go down, you have to be prepared for more demand in your community care, because there's going to be more demand from more patients, for more home care services, potentially long-term care, because the hospitals are looking to aggressively shorten their length of stays. So the community care sector has to be prepared for a major policy implementation in the acute care sector, namely activity-based funding. So these are the kind of things you have to think about as you're moving forward with policy changes. And lastly, and this is a summative slide regarding my perceptions regarding activity-based funding in Canada writ large, not focusing on any particular province. Can activity-based funding be credibly implemented across Canada? And my opinion is that yes, with a number of steps in place. Ontario is using it. Quebec is expanding their program, which is called Paiement Accès sur le Patient. And they are making significant investments to move forward with activity-based funding. So we see Ontario and we see Quebec already moving forward. It is the European norm. Can it be done in Canada? I don't see any technological or management issues associated with stopping it in its track. So thank you very much.
Thanks very much, Jason. And people can think as we go through of potential questions that they might want to ask, but we're going to proceed with both presentations first. So I'd like to call on Dr. Sumner Glenn to provide a bit of an overview of the history of activity-based funding in Alberta and the current initiatives. Let me see if this works. There.
Thanks very much, John, and thanks for inviting me to give a talk here at this event hosted by the Institute for Health Economics. I'm very excited about the current initiative here in Alberta, and thank you, Jason, for the summary of activity-based funding and definitions and limitations and benefits. So I'm going to focus on really two aspects here of activity-based funding in Alberta. The first is really just the history, and then the second is related to the current initiative which I'll discuss in a little bit more detail. So just briefly, the objectives that I'll review will be this historical context. We'll go back to 1990, when Alberta had what was then known as the Hospital Performance Index, and then fast forward to 2010, when activity-based funding was implemented for long-term care. And then focusing on our current patient-focused financing initiative, I'll focus on the policy goals, the targeted procedures that have been identified so far, our initial approach to pricing, which is an ongoing project, and our implementation timeline. So the history of activity-based funding in Alberta dates back to 1990, and that's when the government of the day realized that potentially we could improve hospital efficiencies by rewarding acute care hospitals that had the highest acuity of care and funding that uncontrollable cost variation which was noted at the time. So the goal was also to introduce equitable financing determined on the basis of case workload. So this was the element that was deemed activity-based funding at the time. And there was a development of a case mix-based hospital performance index which allowed direction of funding to those hospitals with the highest performance. So this was a novel mechanism at the time compared to the block contract or global budget at the time. Implementation was started in October of 1990, and basically this reallocated a very small percentage of the hospital budget, about 1%, based on this case mix risk formula. And then it was expanded, and at its peak was only about 5% of hospital financing. And as a result, that was quite limited in terms of its impact. The other limitations was that it was not based upon Alberta source data. The government actually purchased case mix data from New York State and applied it in the Alberta context, made adjustments, and then excluded hospital-based outpatient care. So, for example, elective procedures. So its impact, as mentioned, was limited, related to the relatively small fraction of the hospital budget that was allocated for this project. And it stopped as the province moved towards regionalization of hospital care, and at that point, population-based hospital financing was introduced. Fast forward to 2010, the initial approach to activity-based funding was related to long-term care, and the stated policy goals, according to the documents available that I reviewed, was management of the prices and volume per location, and to also use a case mix formula to create uniformity and equity of the financing model. There were financial incentives made in place for efficient providers and to meet established standards for quality of care. There was a lot of heterogeneity in the financing of long-term care facilities at the time, and this hoped to make it more uniform. So it was planned initially over 6 years, from 2010 to 2016, and it was intended to include acute care and mental health services. However, that project was stopped, related to deemed to be not feasible, and it was just continued with global budget financing and after 2016, particularly in long-term care, or particularly rather in acute care. So in terms of the implementation for long-term care, the case mix classification was used a standardized, internationally accepted system of risk stratifying patients. So as Jason alluded to, diagnostic-related groups for individual residents in long-term care. It updated the placement classification every 90 days, or if the patient was newly discharged from the hospital. However, there were some challenges identified with a patient classification system by the providers. There may have been some element of upcoding and gaming of the system that were noted, and some providers had difficulty adapting to this payment model, which was a different form of revenue generation. I could not find any data on key outcomes that how things changed sort of before and after with this model. So I'll now focus on our current initiative, which is called patient-focused financing. It's also activity-based funding, just a different brand term. So the policy objectives here, again, similar to what Jason had already outlined, we want improved access through reducing wait times for targeted elective procedures. We want to incentivize technical efficiency in hospital operations, i.e. lower cost per case, ideally. And then we want to introduce what's known as inter-hospital yardstick competition with public financing. And this means basically that different institutions that do similar procedures will compete on the basis of the price signal. This also will introduce some financial accountability for hospital managers. And ideally, we're aiming for high-quality patient outcomes from the hospital-based care. So this is, as Jason alluded to, is an important monitoring function as this initiative gets introduced. So what are the initial targeted procedures that we've decided on to implement activity-based funding towards? First, it's elective hip and knee arthroplasty, elective shoulder arthroscopic procedures, outpatient computed tomography and magnetic resonance imaging services, and elective cataract surgery. So this is our proposed implementation timeline. You can see already that the patient-focused funding working group was established in March of 2025 and was announced formally on April 7th of 2025, and we're now in the process of working towards the methodology and combining that with the information technology group with a target to have between July and December 2025 pilot implementation. In other words, benchmarking of these prices in the targeted procedures, and then proceeding with the spread and scale of this patient-focused funding methodology between October and March of 2026, with full-scale implementation targeted for fiscal year 26-27. So this is how we're structured right now. We have the committee of the Patient-Focused Financing Implementation Working Group, and we have sub-working groups with dealing with methodology, essentially pricing mechanisms, and the Patient-Focused Financing IT sub-working group. We're also interacting between those two sub-working groups to deal with the needed information technology infrastructure along with the pricing. So a question comes up is, what's different from prior implementations in Alberta? Well, there are quite a few differences here. The first is the use of Alberta-based patient-level dynamic costing data to inform patient classification and pricing. So Alberta already has a very rich source of patient-level costing data that we can use to inform our prices for the select procedure. And this, of course, is different from the 1990 iteration where we had to import the case mix groups from New York State. So we do have now, which is different from 2010, we now have implemented a province-wide electronic medical record for the legacy acute care hospitals, and this can facilitate real-time costing and potentially real-time billing functions as well. So this infrastructure was not present in the iteration between 2010 and 2016. Other aspects is that we've got a targeted implementation, so it's going to be relatively gradual with the price benchmarking and pilot introduction prior to the full-scale implementation of activity-based funding. And importantly, this will ultimately account for a higher percentage of the overall global hospital budget than the Hospital Performance Index, which reached only 5% or thereabouts in 1990 to 92. It also, importantly, particularly in orthopedic procedures, it will leverage the existing care pathways that have been developed widely across the province, particularly strong in the orthopedic arthroplasty realm. So that limits the variation in care and helps with the overall implementation of the activity-based funding model. So I want to just mention about pricing approach, and Jason did allude to the components of pricing. I first want to just describe our basic principles. we first of all want it to be transparent and reproducible and validated in similar jurisdictions. So in other words, if we arrive at a price for hip arthroplasty, for example, we want it to be comparable to a jurisdiction in Canada, for example, like Ontario. We want to compare that. We want to balance simplicity with specificity. What that means is we want the pricing system to be manageable by the stakeholders without too much complexity, but still we want the patients to be well defined so that it reflects the costs of the hospital, that the price reflects the cost. So very importantly, and much different than the current hospital financing models now, is it's iterative, meaning that these prices ideally will be updated on a yearly basis and informed by contemporary data with some pre-specified lag time. So in other words, Australia, for example, uses approximately 2 to 3 year lag time between their costing data and their pricing, which is updated yearly. So just to reiterate what we're pricing, as Jason alluded to, we're creating specific hospital products with a pre-specified price, and that includes, among other things, I've included most of the elements here, but patient age and comorbidities, the procedure-specific costs, and procedure-specific complexity factors. So all of this is bundled into a product which is known as a diagnostic related group in many jurisdictions, but essentially thinking of it as the hospital product for which that price is paid for. So if we call it the Alberta optimum price, one formula is the average cost of the procedure across all centers that perform the procedure to a certain threshold volume so that it reflects a generalizable cost. We multiply that by the resource intensity weight, and I put an asterisk there to really just, that is associated with what I've just described in the previous slide, the diagnosis related group. So risk stratified per procedure complexity for patient comorbidities and other risk factors. And then adjustment factors are applied, for example, urban versus rural, teaching versus non-teaching facility, chartered surgical facilities which have different financing needs, and versus legacy hospitals. So one of the things that I haven't included in is capital costing and capital depreciation. So this is just an example of how complex it can be. So this is from the Australia pricing manual for activity-based funding on an acute basis. So you can see the components of this is the price weight, which is determined by the diagnosis-related groups. That's at the front end of the formula. There are a variety of adjustment factors that have been created, including for, I'll show the list, but including for COVID-19, including for ICU care, including for residential status, other factors. And then this multiplied by the national efficient price, which is essentially what I showed earlier, which is the Alberta optimum price equivalent. So it's the average cost over all of the hospitals that provide the service. So this is some of the adjustment factors that are used, for example, in Australia: pediatric status, sociodemographic status, rural location, dialysis, radiation therapy, COVID-19, and then treatment in the ICU. So just a brief example of what can be components of the pricing, and there's a variety of ways to do this for each jurisdiction. And that's all I have.
Okay. Oh, it does work. Great. Thanks very much. And so open to questions that people might have, hopefully, or I'll provide some as we can kind of go through. But I don't know if anybody had any particular questions. Dr. Eagle.
Yeah, I think this is a question for Jason. You mentioned that jurisdictions don't go fully to ABF. How is the decision made as to what's going to be in base funding and what's going to be in ABF? What are the factors that have led to Ontario, say, being 20-25% ABF? How do they come to the balance, and are they happy with the balance they've achieved?
Is this working? Okay, there we go. So I would say some settings use a variety of different funding policies to remunerate the acute care hospitals. In other countries, they can use full implementation of activity-based funding by specifying the entire product list and price list for all hospital activities. Many countries use a variety of policy tools as well too, such as Ontario, such as you described. What the determination for Ontario's list of activity-based funding or proportion of funding remunerated to hospitals using activity-based funding is a very, I think, masked process that is a combination of political factors, practical pressures applied by hospitals, and a desire to reduce financial and activity risks in the hospitals as well too. So they didn't want to go all in and say we're moving to activity-based funding. It was advertised as moving towards a full implementation at one time, but then it was scaled back, and it was in conjunction with a bunch of activities happening in Health Quality Ontario, an organization that specified clinical pathways for all of the activity-based funding products. But the full clinical pathways were never included as the QBPs, as the funded activity defined. So they just used essentially the groups that Health Quality Ontario created handbooks for, still available online through Ontario Health, but they never implemented the quality aspects to it or the staffing models or the post-acute care pieces to it. I would say in Ontario that they do use a variety of funding policies, including activity-based funding, but they still use global budgets a lot, and they still use a lot, or a little bit of what they call bundled payments too, which are viewed as the successor to activity-based funding because they link in the community-based care following the acute care discharge. So that has been poised to be growing as a relative proportion of hospitals' activity in Ontario, the bundled payments. So it is, I think, in every setting, a very complicated tapestry of political decisions, what senior executives feel the hospital sector can absorb in terms of change management, plus their experience and ability to adapt to new models. So it's been a very interesting journey, whereas in Quebec, the acceleration into a fuller activity-based funding model has been much more rapid, for example, and they really want to push it out more quickly. So I don't think there's anything clear that would say this is the decision point of why we're moving to this level of activity-based funding, unfortunately.
One follow-up is, well, thanks for the answer, really appreciate it. And is physician funding often included or often excluded? If you look at Europe versus Ontario, Quebec, what's
Great
happening
question.
on physician funding?
We were talking this morning about this, and the norm is not to include physicians in activity-based funding, and this is for a variety of reasons. So for example, in most European settings like the Nordic countries that use a range of different funding models like global budgets and activity-based funding in conjunction, most of the physicians are hospital employees. So that there was really no value of unbundling them from the bundle because the set amount includes the physician payment. In Ontario and Quebec, both are acute care funding mechanisms solely and exclude physician cares. So physicians are not included in the bundled price or product definition. The only way that, there is a latent financial incentive for physicians to support activity-based funding because there's an incentive for more activity. In both of those provinces, most specialty physicians, such as the one shown here by Glenn, are remunerated on a fee-for-service. So the more they can do, the more they'll be remunerated and are supportive of the activity-based funding policies. And that's where I think you've seen a lot of the provincial medical associations historically have lined up behind supporting activity-based funding because it's associated with higher levels of spending by government on acute care. And accordingly, some of that falls over to physicians. So in short, they are excluded, but there is a latent incentive for more.
Thanks. Are there any other questions from people? Oh, Steve.
Hi. So as a layman, so one question off the top. We've talked for decades about how fee-for-service for physicians is the problem that we need to get rid of. But in hospitals, effectively, fee-for-service is the solution to our problems in hospitals. So when you talk about it in hospitals, I wonder, are you really talking about moving to a pure activity-based funding system, or one with a volume incentive where you keep base budgeting and you really just have a volume incentive? And so for physicians, would we be better off to think of it in those terms as well? Have base funding, probably capitation funding, with a volume incentive. It isn't really one or the other. It seems like a blend might be better for both. But then on activity-based funding particularly, totally get how we need to standardize funding. I mean, it's like clinical variation. Ridiculous that we tolerate the amount of variation we have in physician practice, and also ridiculous we tolerate the amount of variation we have in resource use. Of course we need to standardize it, and if activity-based funding does that, that seems like a big win. But what makes my head explode is the thought of a pure activity-based funding implementation where the price setter would determine the allocation of services across the whole system. You take away the function of hospitals or regions or whatever service deliver in determining what's needed for the patient who comes in the door, and you vest that in the price mechanism. Is there really a jurisdiction where the price mechanism determines the allocation of services? Or are you always going to have hospitals determining what gets done and then the pricing will follow after?
I'm happy to take a first stab at it, but I think you brought up about 6 or 7 different points. And I'm happy to work through my response to each, although some of them are not sort of grounded in the evidence and certainly transitions into my own opinions. And I don't know, they're only my opinions and they're worth what they're worth, I suppose. So, you know, a global budget with volume incentives is certainly another policy option. I mean, there are many options that we've talked about, and here I was talking about, you know, the predominant and most common approaches to funding acute care include a blend of global budgets and activity-based funding, and usually excluding in the Canadian settings, or always excluding in the Canadian settings of activity-based funding, physicians. Is it the right or the best? Well, there hasn't been a lot of experimentation. This is a retrospective payment model. So that means it could be applied prospectively such that every time a patient shows up at the door, there's a funding amount provided by the government for that patient. But generally, there's a reconciliation process that happens, you know, months or years later. Well, not years, but quarters later, that looks at the actual funding the hospital received and the activity-based funding proportion, and there's a reconciliation. So not all patients are expected to generate a profit that the hospital can reallocate to, say, new imaging services or reducing congestion in the ED. I mean, they're publicly funded institutions, so they're not profits to shareholders. They're free money to, or not free, but they are monies to be reallocated according to the hospital executive's desires or community pressures, as it would be. So it's not clear whether or not a different model would achieve the same aims, because we just don't know enough about them. But whether or not every patient that shows up is going to generate a profit is unclear, and I don't think that's the expectation. Because as you're talking, one of the points you made was about the regional variations in clinical services. Absolutely, and ABF was one of the policies used to tamp down regional variations in provision of services. And this came out of the United States with the regional variations literature associated with trying to understand why the service was provided here but not here, and 10 times over here. So activity-based funding, which sort of sets a common price, creates a standard financial incentive and tries to tamp down the clinical variation of the hospitals. So I think I hit about 3 of your points. Are there any remainders? I'm happy to go after, or maybe Glenn has other points on that too.
Well, I just wanted to mention that it's important to distinguish for hospital payment models between fee-for-service and activity-based funding. They are quite different. So fee-for-service for hospitals, of course, you can have multiple different fees that are picked up within each episode of care, whereas with activity-based funding, it creates a fixed price for the entire episode or the well-defined episode of the care. So if you introduce activity-based funding in a previously fee-for-service hospital payment system, you do reduce costs. That was actually one of the things. Now, when you introduce activity-based funding with a global budget financing, 100% global budget financing, then as Jason alluded to, most often the costs will go up, or the costs related to hospital care will go up related to the higher volume of care. So it depends on which system you're introducing it. But the key components of activity-based funding, it creates a fixed price for the given costed episode of care. So it's quite different from fee-for-service with regards to hospital payment.
Yeah, okay. I had a question, but I'll just zip over here. No, okay, I'll go first. Just one quick question. I was wondering in terms of the scope, Glenn, in terms of discussion with the committee as far as full implementation in 26-27, which I think is ambitious, but is that implementation of the procedures which have been identified broadly? Or is it like all funding for hospitals is going to shift to kind of all additional services in 26-27? I'm just wondering about the scope, whether it's full implementation of the services which have been identified, and whether any talk about what percentage we're looking at in terms of hospital funding in 26-27.
Yeah, I actually think that's to be determined. I think the first iteration of the targeted procedures are those that are believed to be most amenable to the pilot project and then implementing full financing at that 26-27. That's my understanding. We haven't received any further direction about the entire scope of the project in terms of the percentage of all hospital activity to be financed.
And just to comment and follow up, Jason, I know in transition to activity-based funding in a number of jurisdictions, there become winners and losers based on their past activities, and some jurisdictions have set limits of percentage change. If you have a really inefficient hospital, you're not going to lose 40% of your budget, but there may be some limits of transition over a period of time to get the behavioral and organizational change of shifting resources across hospitals. So I don't know if you had any comment on strategies that look at that in terms of what are the maximum wins or losses for hospitals.
Yeah, I mean, implementation of a major new model that moves hundreds of millions or billions of dollars around is a risky proposition for governments and for hospitals. I mean, in no way does the government want community hospitals to be closing because of the policy change. They only want to see the positive change, the more cost efficiency and more volume and reduced wait lists. So they are, when they implement, they generally tend to put in policy redresses for those that are not able to effectively manage the implementation, such as redlining their budgets, which would mean no actual decrease associated with the new policy change. So that there are policy steps that governments make to make sure that hospitals are not going to be at financial risk in the short term. Over time, they hope to pull back these red line mechanisms as the hospital gets up to speed, for sure.
So I just want to go back to the product versus the pathway. So when thinking about activity-based funding based on specific product that's being looked at, how is the remainder of the pathway, so rehab, for example, and surgical procedures, implemented or integrated into this? Is that part of the product piece that's being looked at up front? And in particular, I'm thinking about if we increase surgical volumes in urban centers or in more of the urban areas, and patients are therefore discharged sooner back to their home community, but they still need support services, even acute inpatient rehab. How will that be integrated into ABF?
Yeah, that's an excellent question, and the answer is it's not at the moment integrated into the entire pathway care, the activity-based funding is for the episode of care that occurs at the hospital level, and you've just very quite eloquently identified one of the stressors of that can be a problem with activity-based funding, which is the decreased length of stay and early discharge, putting some stressors on the post-acute care facilities. And that's actually documented in the literature. So it is important. It is important to be ready for that, in a sense. So having a care pathway in place, ideally. So some of our procedures do have, the targeted procedures do have clinical care pathways in place, including for home care, for rehab, so post-acute care. And I think of the procedures that come to mind are the orthopedic ones, where they're trying to get early discharge already. So it's a great question, though.
Thank you both for your presentation. I had a question. Last week, the C.D. Howe Institute published a paper about innovation in healthcare and how capacity constraints is one of the biggest issues. And looking at Mark Leduc, healthcare hospitals are always the in-kind contribution to an innovation project. Where have you seen innovation and research factored into the funding formula to allow for that surge capacity to actually change the system? And have you seen it in other countries where it's been effective and how it's worked?
I'll take a rough stab. Generally, research and innovation have been extracted from the payment models to the degree that's possible. So for example, as Glenn illustrated with the Australia model, they try to adjust for different factors or pull out different factors. Certainly in Ontario and Quebec's implementation of activity-based funding, they try to extract as much as possible the research functions from the payment levels to try to untangle those pieces to the degree possible. Who knows the degree to which they have been successful at that, so that there's a clear innovation bucket and a clear research bucket, and other buckets as well too, like clinical trials and pieces like that that you don't want the ABF programs to be funding, unless you're allocating surpluses between profits and prices. But generally, most implementations try to take those out of the prices and fund them separately. I can't speak to Alberta's position on this, though.
I agree with Jason about the research and innovation part. You alluded to capacity, and I think that's a very important question that Canadian publicly financed hospitals have struggled with capital investment, and because the return on investment is not always clear. So I think that's a question that has to be addressed, and ideally the capital depreciation would be factored into a given acute care facility that's being financed through activity-based funding. But I agree with Jason. I think that what we're going to see is that research and innovation will be separately financed, not related directly to the activity-based model.
One thing that I didn't include in my presentation, and I don't think has been talked about this morning, is the issue associated with activity-based funding called carve-outs. I don't know if people are familiar with what carve-out means, but carve-out means taking the global budget and taking the monies away that you're going to later remunerate through activity-based funding. So how much is the payer going to take away from the global budget that the hospital is going to earn back later with activity-based funding? In a couple of different places, the carve-out methodology has been very contentious. Okay, so I just wanted to flag that as something people really need to think about carefully, because how much money are you going to claw back from the initial global budget amounts that the hospitals are going to earn back through their activity later throughout the year? Like, how do you set that price and volume just for the carve-outs?
Yeah, and certainly there's some past history in Alberta in terms of that, where there's been some challenges in terms of held back resources, even on executive payment kind of thing, in terms of kind of earning things. Just a couple of quick questions. We talked about physicians, but also hospital. And I'm wondering if Jason or Glenn, other frontline providers, particularly nursing and various kind of groups, where there's any lessons internationally in terms of issues that have come up, which are the key implementation concerns regarding non-physician and engagement there. And just a second quick question is, political leaders talk about activity-based funding, and if there's any, is there some kind of fact which gets presented which is often misunderstood, or even around the world, where political leaders said this is going to save money or this is going to do this, of if you had to advise political leaders, be careful about saying this is an objective of activity-based funding. But first, other frontline providers besides physicians.
Yeah, I'll take a stab at the non-Alberta settings first and then hand over to Glenn. I think what you've seen across the Canadian implementations, first in British Columbia and Ontario and Quebec, was that the nursing unions and nursing representing the largest cost bucket of acute care hospitals are generally opposed to the implementation of activity-based funding. And the reason being, as there's some financial incentives to decrease length of stay, that there is a perception and that the portion of the acute care length of stay will be the most acute part, because you're pushing them out faster, so that the nursing workload will increase associated with the implementation of activity-based funding. So generally you see the nursing associations and unions coming out against activity-based funding policies. I haven't seen it for the other allied health professions like rehab, as you noted. It's hard to say with that impact there. I haven't seen any research on that area, although there are implementations of other types of funding policy that try to take that rehab focus, such as bundled payment, which would include, the community-based care to restore function across the recovery trajectory, for instance. But that's not included in an acute care focused activity-based funding model. On the second point, I think that it would be very risky to say activity-based funding saves money. I think it's much because of the clear evidence that implementations tend to increase volume and increase spending. I think it's much safer to hang your hat on saying hospitals will do more surgical activity. That generally tends to be true. And is that a bad thing or not? I'm not one to opine on that, but if that's what you're trying to look for, activity-based funding will push more volume.
Yeah, just on that latter point, I think the key is that it depends on which financing model you're transitioning from. So, for example, in the early 1980s, when the United States was implementing activity-based funding, it was from a fee-for-service system to activity-based funding, which did actually reduce costs. But we're talking about global budget financing or block contract financing, and if we go from that model to activity-based funding, I think, like you pointed out, I think almost always the costs are going to increase because the volume will increase. Regarding, I think, the first question, I just would point out that perhaps make the point that between 60 and 70% of the hospital budgets constitutes human resources. And as Jason alluded to, the bulk of those are nursing resources. So it's incredibly important that we engage the nursing and allied health professional stakeholders when we're doing this transition. One way, in some jurisdictions, mainly the US, there may be incentives in place for the team to actually meet or go beneath the price to actually share in the savings that may be present in any given episode of care. So if it's a team-based approach, which does sort of expand the model to not just the hospital payment, but to the physician and the physician team, then there can be another element of incentive called shared savings, or where the hospital makes money, so to speak, by doing the procedures under cost. So that's just another option.
Okay, and Mark, and then I'll call on Jason and Glenn if they have any final comments of cautions or words of kudos for pushing forward, but last question to Mark.
Thanks, John. Thanks, Jason and Glenn. You definitely got the wheels turning. I guess two questions. One is around the competencies. I forget which of you spoke to this. It might have been you, Jason, around the payees, the hospitals, also need their own capabilities to understand the financial implications of choices they will make, what they might do with unallocated funds or any unspent funds that they generate through the ABF model. The payer also needs their capabilities to assess, and then at some point, I guess there's some sort of auditing or reconciliation process between the two. What, given the shared services model that Alberta is moving to for health services, I'm just trying to think of how do you support the two functions without putting them in conflict? They're all using the same source data, I guess, and then we have some controls around how the coding might be, because HIM might be in a separate entity. So there's some things that we might avoid that other jurisdictions may have run into. But I don't know if you can elaborate a little bit on what that financial competency looks like, or what you've seen in other jurisdictions around the infrastructure needed by the payees versus what the payers need. The other one was around the link back to appropriateness and quality. How have jurisdictions, perhaps in other countries, looked at how to link back or avoid just the sheer incentive of doing more for the sake of doing more versus being accountable for the outcomes that are generated? You touched on, I think, Glenn, around the bundle payment model is another mechanism to try to align the incentives. If you could elaborate a little bit more on how we might think about that going forward with our models.
Well, maybe I'll take a swipe at your question/comment around potential perceived conflicts between payer and payee. And I'm not sure that I would characterize the implementation of activity-based funding as a conflict between the payer and the payee. In fact, I would view it as, this is a new policy implementation. We need to be on the same page regarding the implementation, but the strategies needed for implementation for the payer, which has to define the product and the price, and the payee, which is the sort of the receiver of the product definition and the price. I mean, those skills are not necessarily exactly the same, but I wouldn't say that they're in conflict with one another. But they will be exploring weaknesses in the product definition and the price definition to try to, earn rents or unearned profits. But that's something that the payer has to really be active on and working with, understanding the incentives for volume and activity that it's creating through the activity-based funding policies. But I wouldn't necessarily deem it to be a conflict with one another. With regard to the other piece around quality, I haven't seen a lot of implementations associated with a quality incentive in the ABF, except that Medicare did implement, what was it called, the QIPS program. And there was a slight financial incentive associated with higher quality, which was the traditional quality indicators such as readmissions and emergency department visits post-hospital 30-day or 90-day or whatever it was. And those acute care hospitals that had better perceived outcomes on those measures received a slightly higher bump in their DRG-based payments. So there are exemplars of programs tying quality into the payment rates.
I'll just mention one thing about the Alberta process. So it's a very close interaction actually between the hospital providers, the legacy hospital providers, including HS, Covenant, and we need some more data also from the chartered surgical facilities, but basically trying to get the data from the hospitals, and then AH, as Jason mentioned, would be the payer setting the price, but it's a close interaction between agreeing upon the way the prices are set and then understanding what the implications of that pricing. It also does introduce, I think you alluded to this, which is an element of compliance, so making sure that from the Alberta Health side, there has to be adherence to the pricing, and avoiding some of the limitations of activity-based funding like upcoding and those kind of things to achieve more revenue that isn't valid from the hospital. That's about it. I think in terms of the quality, I think the other thing I'll point out is that Alberta does collect quite a lot of quality data. The question is how to act on it and how to put it in place to integrate with this model. And I think perhaps expanding the model to include physician payment in the long term may be a good way to do that, but that's to be determined, I think.
And so thanks very much. I'll just, if there was any kind of final comments from either speaker in terms of calls to action or cautions or advice, I'll just leave it up to them and then I'll close. So I don't know if anybody had any kind of final words that they might want to make in regard to this issue of implementation in Alberta of pearls of wisdom or advice.
I'll just say I'm really excited about the initiative. I think it's Alberta's uniquely positioned with its rich treasure trove of costing data to inform rational prices. And we're also a relatively small population province that can be nimble with regards to the needed update of the pricing and providing the incentives that actually work well for long-term quality care of the patients.
I guess I could go on for several hours, you know, having spent so much time on this topic. And thank you, John, for inviting me here to talk with you about the experiences internationally and other Canadian settings with activity-based funding. But I think I would highlight some of the pieces that I had on my second to last slide, in that, you know, unless there's a commitment to sustained implementation and growth of the project or the policy, you know, you probably wouldn't expect to see all of the hospitals respond to the pricing signal that would be let out, because the hospitals probably will be kept whole at some level. The government doesn't want them to be at financial precarity associated with the policy implementation. So they see that as, well, I can do no harm, so let's just keep rolling with this. So unless they see a ramp that this is going to become the policy, you're probably not going to see anything. And that's what we saw in British Columbia. Another point is huge coding response in Ontario that almost destroyed about 2 years of their DAD data associated with spurious coding. So be careful on the coding side. And I think lastly is that, you know, if this is about bumping up volume, this is probably the most effective policy tool that most countries have used to bump up volume, but it doesn't save money.
Okay, thanks very much. We will be sharing the PowerPoints and the videos and actually going to be posting some ongoing information. If there's any topics specifically related to activity-based funding, some subtopics, we're going to try and organize some educational kind of series. But please join me in welcoming our guest speakers, and thank you for attending today.